Hello, everyone, and welcome to part 2 of our lecture on Chapter 7 Initial Assessment in Counseling. So, in part 1 of our lecture, we talked about the purpose of the intake assessment as well as some common screeners that are used to help narrow down the work that you're going to be doing with your clients, both in assessment and in counseling. And in the second half of the lecture, we're going to further expand upon that by talking about more specific screeners that you can use with your clients. So before we get too far, I do want to give you a warning about some of the language in our book because our book was published in 2017 and there was a pretty massive update in the language that we use related to suicide in late 2017, early 2018. So our book is outdated in the way that it talks about suicide. So for example, our book might say things like someone committed suicide, but in reality and in our current day, when you're talking about suicide, the proper terminology is to say that someone died by suicide or they suicided. So using suicide as a verb and not to say things like someone committed suicide, completed suicide, or had a successful or non-successful suicide. All of these terms that are in the not category are implying that one, it's a crime to have suicidal thoughts and to engage in suicidal behavior. And the idea of completed and successful suicide almost displays suicide as being something that people should seek out or that it's something that is like a goal to achieve. And as a society, we've moved away from this language. So make sure that in your own clinical work, if you haven't already, move towards things like died by suicide or suicided when talking about suicide. So just keep in mind that our book is out of date in terms of the way that it talks about suicide. So the reason why I bring that up is because a primary area of concern for us as counselors is a suicide risk assessment. In fact, we are mandated as clinicians to assess our clients for suicide during the intake interview. And we do this for a couple of reasons. One is that suicide is considered the 10th leading cause of death in the United States, with a suicide occurring almost every 13 minutes. And worldwide, it's estimated that someone dies by suicide at a rate of 1 in every 40 seconds. So we really have to keep in mind that suicide is common amongst many people, and it is our job to assess and help protect individuals who are experiencing suicidal thoughts. We also see that there are higher non-fatal suicidality rates amongst individuals who are high school students compared to individuals who are 18 years or older. And in this context, non-fatal suicidality can relate to experiences of suicidal thoughts, establishing suicide plans, or attempting suicide. And these higher levels of non-suicidal rates are high amongst the young people in the United States. So it's particularly important and especially important for us to assess them for suicide thoroughly. Also, middle-aged adults between the ages of 45 and 54 are accounting for the majority of suicides in 2001, which was the last date that the CDC conducted research on suicide comprehensively. So you can see that suicide is important. So assessing suicide is a key part of the initial assessment in all of counseling and assessment. Counselors must directly ask all clients about suicidal thoughts with increasingly more specific questions if the risk for suicide is elevated for any clients. It's important for us to engage in a collaborative assessment process so that clients may feel validated during a likely stressful time in their lives. You, as the clinician and as the assessor, need to establish rapport with your client by approaching the topic of suicide as if you were talking about any other topic in your intake session. This approach to a suicide assessment reminds your client that one, you will not be fazed by the responses that they give, but two, it also reassures the client that you will be calm if they need to come to you in crisis in the future. Also, keep in mind that talking about suicide does not increase one's risk for experiencing suicidal thoughts or attempting suicide. Rather, asking provides the necessary outlet that individuals need to talk about these thoughts and these actions. And keep in mind as well that the goal of a suicide risk assessment is to identify the level of risk. ranging from no risk to high or imminent risk. And the levels of suicide risk can range, with higher levels of risk requiring higher levels of treatment. So even potentially requiring hospitalization. So, as a clinician, it is our responsibility to make sure that we are identifying the level of risk for each of our clients individually. In fact, when we get into the second half of our semester and we're talking about the actual application of an assessment, suicide risk assessment is one of the most important things that you have to gather in your intake interview. In fact, Brad will often say in the clinical classes that you can forget many things during your intake interview, but there are a few things that you can't. One of them is you have to get informed consent and discuss confidentiality with your client. And the second is that you have to do a suicide assessment. You have to assess risk, otherwise, your session is going to be problematic. So, some of the key things to keep in mind about suicide is that there are some common correlates or risk factors that are associated with suicidality. And those broad stroke considerations include individuals who are white, being an unmarried male with less formal education, having particular psychiatric and substance abuse disorders, encountering stressful events, and having previous suicide attempts. And again, it's really important to remember that given the complexity of suicide risk, counselors should use these components as simply broad stroke considerations. This is not the case where if someone has all of these things, they are automatically going to have suicide risk, or if someone has none of these things, they're not going to experience suicide. Neither of those things are true because there's so much variation in how suicide and the risk for suicide vary for each individual. Oftentimes, when we are looking at significant factors of suicide, we start by asking very open questions, and they're very direct. So you might use questions like, how likely do you think it is that you will act on your thoughts of suicide? Or how long can you continue to tolerate the situation as it is? And when we ask these questions about suicide, we are often trying to generate the client's self-reported suicide risk. And this is an important factor in determining if our client needs more help than what we can provide them in session. If a client is at higher risk, we need to be taking their responses to their self-reported risk seriously so that we can determine if they need to be hospitalized at any point. Also, counselors need to assess 3 components of a client's suicide plan, including the lethality, the availability of means, and the specificity of their plans. So if someone has a plan for suicide, we need to determine if their plan is likely to be lethal, if they have the availability to carry out that plan, they have all of the resources necessary, and how specific the plan is. If their plan is more lethal, has more and they have more means, and they're incredibly specific, this is going to increase one's suicide risk. Also, the most predictive indicators of suicide risk are ideation, plan, intent, and means. So when you have a client who has all of these things, it's really important to take any of their suicide risks incredibly seriously. We also need to assess suicide history in terms of the client's previous suicide attempts, as well as a family history of attempts or suicide, because it helps us to gauge their risk during the suicide risk assessment. There are some additional factors that we also have to consider during a suicide risk assessment, which can include the presence of psychological symptoms and or substance abuse, as well as environmental stress, the availability of resources, both internal and external to the client, and the fact that certain individuals are at higher risk for attempting suicide more. So if someone is male, if they are of particular ethnic and racial groups that are at particular risks, such as individuals who are indigenous. And although all client symptoms should be reviewed, critical symptoms of suicide risk include things like acute suicidal ideation, severe hopelessness, attraction to death, and acute overuse of alcohol. Other warning signs are recently being released from a psychiatric hospital, experiencing major life changes, anniversaries, recent changes in antidepressants, and recently coming out of a deep depression. Particularly, changes in antidepressants and recently coming out of a deep depression are risk factors for individuals for suicide because likely right after a deep depressive episode or immediately after, not necessarily immediately, but shortly after a change in antidepressants, the individual is likely to see a change in their energy levels, and they're likely to have more energy to act on their suicidal ideations, which can be a particular risk factor for someone. There are several assessment tools that are available to counselors to help assess and intervene in suicide risk. And these assessments can help to ensure that you, as a counselor and as an assessor, don't overlook crucial factors in making a decision about suicide risk during the initial interview process. So, all of these aids are going to emphasize the importance of assessing current suicidal symptoms as well as suicide history. And again, similar to the screeners that we talked about in part 1 of our lecture on chapter 7, each of these suicide risk assessment aids are going to be similar in some ways, but may have slight differences. And it's really about using the assessment that makes the most sense for you, but also might be the one that your agency uses. So the first of these is called the SAD Person Scale, which provides a convenient acronym for the 10 factors to keep in mind when you're assessing a client for suicidal risk. Those include sex, age, depression, previous attempt, ethanol abuse, rational thinking loss, social support loss, organized plan, no spouse, and sickness. Clients will receive 1 point for each factor of SAD persons that are endorsed, and then all clients who receive more than 2 points should be considered at risk and that you should assess them further. In fact, our textbook would tell you that anyone who scores 2 points or higher should be considered for psychiatric referral or hospitalization, and that will vary widely depending on your agency. So make sure that you're paying attention to and asking your other clinicians what sort of threshold they use with the SAD Person Scale if that's the aid that you are using. Another assessment that can be helpful is the Suicide Assessment Checklist, which includes 12 items based on the client's suicidal planning, suicidal history, psychiatric history, drug use, and demographic characteristics. And each of these there are an additional 9 items that are based on the counselor's ratings of significant factors in the client's life. So the counselor or the assessor is going to assess the client's hopelessness, worthlessness, social isolation, depression, impulsivity, hostility, the intent to die, environmental stress, and future time perspectives. And we use both the self-report and the clinician report to help provide the most comprehensive insight to the client's suicide risk, because the client might not be aware of all the areas of their life in which they are experiencing risk. And depending on the item, there are certain items within the suicide assessment checklist that are weighted differently in terms of their criticalness. But overall, depending on which one you use, higher scores in total on the suicide assessment checklist indicate greater risk. Another assessment is the suicide assessment and 5-step evaluation and triage model, which was developed to help reduce the number of false positive suicide attempts. And the 5 steps include identifying relevant risk factors, identifying protective factors, conducting a suicide inquiry, including current suicidal thoughts, plans, behaviors, and intent, determining level of risk and select interventions to reduce risk, and documenting the assessment of risk the rationale for the chosen interventions, and follow up after assessment and interventions. So, again, this suicide assessment 5-step evaluation and triage is just a way to help organize the most important pieces that you have to gather in assessing someone's suicide risk. So, it's less of a specific checklist that you can use and more of a procedure that you can follow. There's also the decision tree assessment strategy, which uses 3 risk factors: past suicidal attempts, suicide plans and preparation, and suicidal desire and ideation as the basis for assessing suicidality amongst clients. This approach helps the counselor to readily identify clients who will need further assessment. So it's the really quick approach to figuring out who needs a much deeper approach to suicide assessment and who can just ask these broad questions and then move on. And although it's considered an intervention rather than an assessment aid, safety planning can actually help minimize suicide risk. So, safety plans can vary widely from one another, but some general components of most safety plans include identifying warning signs for each person, identifying internal coping strategies, providing examples of social situations and individuals that can help if the person is experiencing suicidal ideations, and noting different specific individuals that can be of help that you can go to, and identifying professionals or agencies to contact during crisis. And overall, if you have any questions about suicide, especially very early on in your career as a counselor, consult as often as you need and do it as much as you need, because there is no harm in having a second opinion on a client's risk. So talk with your peers, talk with your fellow coworkers, ask them if they can sit in and listen to a recording of your client and get another opinion on their risk. Even bring that person into the room with your client so that you have 2 people making a decision on how to approach the client's risk. So the last thing that I want to talk to y'all about in regards to Chapter 7 is what we've been using up until this point for diagnosing, which is the Diagnostic and Statistical Manual, or the DSM. And the latest revision of the DSM-5 text revision, was published in 2022, so it was published recently, and includes categorical and dimensional assessment component or opportunities for counselors. So the categorical assessment refers to noting whether a particular symptom or a particular diagnosis is present, whereas the dimensional assessment is going to provide you with the degree to which a symptom is present. So another way to think about this is that a categorical assessment will tell you the kind of something that someone has, the kind of diagnosis, whereas the dimensional assessment will tell you the degree of it, so how severe it is. And the DSM is really unique. If you've never gotten an opportunity to explore one, let me know and I'll send you a PDF copy of the last DSM, the original DSM-5 from 2013. I don't have the text revision in PDF form, but I do have the 2013 form in PDF. So let me know if you've never explored it and I'll send it to you. I'm happy to do that so that you can get an opportunity to see it. But the DSM is pretty unique in its organizational structure. So there's going to be a lot of words on the screen here, but what this is the specific layout of the DSM. So the order of categories, and within each of these categories is a breakdown and a description of every diagnosis for mental health. So you'll notice that typically the way that the DSM is organized is that the earlier categories tend to be really biological, and the later categories tend to be a little bit more social, according to research. I don't know if I always believe that, but that was the initial intent and the organization of the DSM. But you'll see that there are quite a few different sections within the DSM, and it can sometimes be complicated in trying to find your diagnoses. So if you're super nerdy like I am, you put little tabs to help you float through the DSM a little bit faster. But the DSM is not a perfect system. There are definitely some challenges related to the DSM, specifically around diagnosing in general, including some concerns regarding the lack of transparency during the developmental process. Specifically, the way that they develop the DSM is secretive, and it can make it really difficult for us as clinicians to distinguish mental disorders from normal distress, while also giving us this lack of empirical validation for the dimensional assessment scales, as well as the presence of diagnostic errors due to cultural bias factors. We don't have great methods of diagnosing right now that don't account for these things. So, in other words, we don't always have the best scales within the DSM to determine the degree of someone's diagnosis, or how much their diagnosis is due to normal distress versus a mental disorder, or how much culture plays into it. And one of the particular ways that this shows up is in diagnostic variance, which is varying clinical decisions amongst providers. And this diagnostic variation is common during the diagnosis process. Unfortunately, individuals who are racially and ethnically diverse and other individuals with more minority statuses are disproportionately given more severe diagnoses, which is a problem with the DSM that has not yet been addressed. And I'm hoping that as the DSM continues moving into future editions, we as clinicians can move further away from this diagnostic variance. So that is where we are going to wrap up chapter 7. As always, here are the review questions to help you make sure that you are gaining or understanding the important components of this lecture. And I will see you all in the next lecture.